So welcome everyone and happy Nurses Week. Thank you for joining us for today's webinar. My name is Erica Bloom and I'm the Product Marketing Manager at Springer Publishing. For those of you who don't know Springer Publishing, we are an award-winning publisher of nursing and healthcare content featuring books, apps, journals, and digital products. Today we are presenting Putting the Pieces Together for Safe, Effective Care with Dr. Deborah Hunt, author of Fast Facts for Patient Safety in Nursing. Dr. Deborah Hunt is the Dr. Betty L. Forrest Dean for the College of Nursing and Public Health. She is an experienced leader, educator, researcher, and author of academic and children's books. She has over 15 years of experience in academia with previous experience in staff development, critical care, nursing administration, and staff development. She is Professor Emerita of the College of New Rochelle and a fellow in the New York Academy of Medicine. She has numerous publications and has published 4 nursing books, with the latest one focused on patient safety. Before we get started, I want to mention that this webinar will be recorded. If you miss any of the presentation, you can find the video at springerpub.com 5 to 7 days post-event. If you have any questions, please type them in the Q&A box on your Zoom control panel. I'll bring them up at the end of the presentation. If you forget to ask a question, there'll be a brief survey at the end, and if you have any question, you can include it there as well. Now, without further ado, I'll turn it over to Deborah.
Thank you very much, and welcome everybody. I'm so glad you joined us on this beautiful day. I just want to let you know I'm in my office at Adelphi University, and I have lucky enough that the softball team is outside of my window. So if you hear any noise, it's probably going to be that they've done quite well. So that's exciting. But again, I just want to thank you for coming. This is such a vitally important topic. And the description overview of this webinar presentation is about patient safety. Patient safety and quality of care are integral to every healthcare setting, and all healthcare professionals strive to promote positive patient outcomes. However, adverse events are still occurring at unacceptable rates. This presentation will focus on the key causes and strategies to prevent errors that can help improve patient safety. So during this webinar, and I just want to share, many years ago, in 1999, when Prioritization came out, I was still in the hospital setting, and it brought attention to how large a scale patient errors were and adverse events. And that stemmed a lot of responses. And for a while, things started to improve. And we're going to talk about what some of those responses had been. But more recently, the error rate started to grow again. And I happened to, at one point, I had gone to the CUSIN faculty development session when that first came out. And that, provided a lot of insight and help into promoting quality and safety education in nurses. And so that was a great intervention. But again, it helped, but not to the status it needed. And a few years ago, I was at a conference, and Linda Caputi spoke, and she speaks a lot about thinking like a nurse and patient safety. And when she was just talking about all the errors and how the numbers had started to increase again, I got so concerned, and I thought, I need to really do some more research on this, and I think I need to write a book on this. And so that's where the Fast Facts book came. So during this webinar, we'll look at the big picture of patient safety, what holistically is going on, some patient safety issues, what adverse events are, and then what are some of the strategies, theoretical and practical, that can be implemented so that we can all create a culture of safety in all of our healthcare settings. So, as we know, there are many, many documents that talk about some of the errors. And what happens in the hospital are that there are preventable errors and there are non-preventable errors. Sometimes they're called, medical errors, adverse events, but they're unplanned, right? So there's something that happens and it's unplanned. And the statistics are very, very alarming because there's recent statistics show that 250,000 lives are lost per year due to an adverse event, and that the cost is in the billions, and some even posit that it's the third leading cause of death. So, and it's not just in the US, of course, it's across the world, but the rates are alarming. And unfortunately, since COVID, some things have increased exponentially. And some of the big things have been in hospital-acquired infections. And of course, we have some significant staffing issues too. So the problem is there. You can do a web search yourself and you can see statistics. Some of the statistics do vary a bit, as far as the severity, but it's pretty alarming, and it's pretty consistent that we do have far too many adverse events. So we still need to do a lot of work on how to improve this. And so these are some of the things here on this slide that have been done. So patient safety initiatives. Back in 2003, the Joint Commission released their patient safety goals, and there were 6 at the time, and now there are 15. And many of them revolve around patient identification, right? Medication administration, particularly high risk, lookalike drugs, wrong site surgery, and there are other things, absence of following up on critical tests. So there are many, many factors involved in this, and they continue to focus on them. And again, they've had positive outcomes, but not yet. We're still missing something. And then, as I talked about before, the patient safety, quality and safety issues for nurses. So I know this is not an interactive video. However, assuming that most of you have heard about that. So in I think 2008 and then in 2010, Robert Wood Johnson Foundation funded this a group of people to say, how can we promote quality and safety? So they developed 6 competencies on quality and safety for nurses. And we were preparing everyone to have knowledge, skills, and attitudes. And the focus was on students thinking that then they were the foundation and would go on to be the safe practitioners, right? So the 6 safety goals are patient-centered care, teamwork and collaboration, safety, informatics, quality improvement. And so it's very important for all of us to continue to follow those cues and competency. And then the National Academy of Medicine, they're the former Institute of Medicine. They have also, a lot of the CUSIN work came from the foundational work of the IOM, but they have also started something where they have a zero harm. So they have an initiative called Zero Harm. And then the the AHRQ, they have the national scorecard on hospital-acquired infections. Now, since I've written this book, I recently did some research, and again, unfortunately, the number of hospital-acquired infections post-COVID have risen to very concerning, even more concerning levels. So again, we still need to do a lot of work on here. And, even basic hand washing, which has improved, can still make a huge difference. And then the Institute for Healthcare Improvement, they have a campaign, Save 100,000 Lives. And, their estimates are that at least 120,000 lives have been saved through their initiatives. The World Health Organization has various safety initiatives, and one of them was the Safe Surgery Save Lives checklist. And then the Affordable Care Act focused a lot on quality and safety and the partnership of patients. And Press Ganey has Accelerate to Zero, which is a very ambitious plan, but hopefully we can eventually get there. And it's going to take everybody, every healthcare professional that is around, to really have a culture of safety focus, because you just have to have one slip and that can just spiral into many, many different errors. So what are some of the common causes? So initially, I didn't really believe that it was communication problems. However, except for a few research studies or experts who disagree, this has been a resounding area of errors. So communication problems, both verbal and written. So it could be miscommunication, misunderstanding, missing maybe an order or an email or a note that's unclear. So this is a very significant area. And we know we're very busy, right? So people get very, very busy. But it's a very important area for us to address. And so again, it could be not recording the information, ignoring the messages, not receiving them. And estimates say that it cost $1.7 billion in errors, right, that result from this. And we'll talk about ways to improve this. Information flow, missing critical test results is another major area of adverse events. And so you can imagine if someone comes back with hyperkalemia or hypokalemia and we miss that and it doesn't get treated, we know it's going to exacerbate. And the effects can be devastating, even life-threatening. Another cause is not following policies and procedures or poorly written policies. So you may have policy and procedures that you review, but if they're not updated and they're not based on current evidence, then they may be the reason an error occurs. So it's important, whatever hospital healthcare setting you work at, to make sure that you are really advocating for clear policies, current policies, and using evidence-based practice. The other issue are patient-related specifics. So we know that improper patient identification, inadequate patient education are main ones. And even though, as you know, the Joint Commission came up with one of the first safety goals was on patient identification and using 2 patient identifiers, that doesn't always happen, right? And I know you can just read the errors that occur, right? So we missed that second step of asking the patient for their second identifier. Or we have a medication call with the Pyxis system, and somehow we override the system. And then, unfortunately, an adverse event occurs. And maybe someone does that 10 times, maybe 20 times. They miss a step and nothing happens. But then by the 21st time, a fatal error occurs. So, we want to do our best to avoid those. And then staffing patterns are certainly related. Linda Aiken has done a lot of work in this area. Again, not everyone agrees and or agrees on what the staffing ratio should be. However, we do know that a mix of experienced and new nurses and healthcare professional team is very important for the safety of the unit and, more importantly, the safety of the patient. And unfortunately, since COVID, we know that this nursing shortage and healthcare professional shortage in general has definitely worsened. So we know that we are dealing with a more challenging situation, and everybody is putting their heads together to try to fix that situation. But it does have to be acknowledged, and we have to think about creative ways to address that. Okay, so as you were told, you can write questions out in the chat. So I just want to give everyone a minute to kind of digest what we've shared so far. And I don't think these are necessarily new, but knowing the severity of these errors may be new to some of you. And of course, different hospitals and healthcare settings have, they may have very few errors. So they may really have this wonderful culture of safety and 0 errors. But I think most places have some, unfortunately. And again, some are avoidable and some are not. So some of the common adverse events, and of course there's others, and there are ones there are statistics that show ones that are more related to medical or nursing or pharmacy or another healthcare professional. But these are just some of the general ones. So falls. So approximately 1 million falls occur every year in the hospital. And they're considered to be the 6th leading cause of death, right? So some falls, thank goodness, do not really result in great harm, but others have resulted in significant harm, increased length of stay, and increased morbidity and mortality. And there's a lot of interventions that are done to prevent falls, but clearly either we're missing something or not all the policies and procedures and interventions are being done consistently. medication errors. This is a major, major, big, giant one. And so medication errors are, um, again, sorry, they're the sixth leading cause of death. I apologize. Um, Not the falls, but medication errors can be anything from an omission, an incorrect dose, an incorrect time, um, a medication that was not indicated for the patient. Some of the high risk ones, of course, are the insulins, heparin, um, potassium. So those are some of the higher risk ones, but medication errors occur at all different times. And, when an evaluation is done, such as a root cause analysis that would be done in a sentinel event, when things are looked at, usually there's something that got missed, right? So either, the person didn't do their 3 checks, or they didn't know what the medication was, or so the order could have been written wrong, and then the pharmacy or the pharmacist should have picked it up. They didn't pick it up. Then it should have been picked up by the nurse. They didn't pick it up. So there's the chain of events. And a lot of times you might think, okay, the pharmacist put this in my Pyxis and it's okay. But you still have to read those 3 times. You have to keep checking and double checking, because we're all human. We all can make errors. And that's why the systems are put in place to prevent those errors. Pressure ulcers, estimates are that there are occurrence of 2.5 million pressure ulcers per year. Now, although not all pressure ulcers can be prevented, depending on if someone really has significant comorbidities and they're, very pure for protein and muscle and health status. However, many of them can be, as long as, again, we're following the current evidence and putting all the protocols in place to prevent a skin or pressure ulcer. So these are things that unfortunately occur at alarming rates still, but they really shouldn't be. And then we have hospital-acquired infections, and all of them have increased since COVID. So, there's been, again, lots of interventions trying to prevent polycatheter insertions, really monitoring catheter sites and checking for all kinds of things and hand washing and following all the procedures, but we still have numerous infections. And so why is that, right? There's a break in the chain somewhere. That's the way it happens. And some are more virulent than others, clearly, but that's still an issue. And, to me, those are the things that all of us putting our heads together should be able to address and prevent. And then other is for you to think about, what are other things that you see in your healthcare setting? What are things that you believe are due because are occurring because of maybe lack of clear policies or lack of staff or patient education? And what can you do about it, right? So I'm going to challenge you to think about, what can you do to create a culture of safety where you are? So I've highlighted some of the issues. I've highlighted some of the causes. I've highlighted some of the strategies and organizations that have done various things to help promote a culture of safety. And so now I'm going to focus on some more stuff that I put in my book. So they're kind of things, of course, they're just not for me. They're based on the review and the research and the literature research I've done. But these are the kind of things I took from my research. So one was, what are the attributes of a safe practitioner, right? So that's a key thing. So what is a safe practitioner? It's someone who is educated. It's someone who has made a commitment to ensuring a culture of safety. It's someone who serves as a patient advocate and a mentor to others, right? So it's someone who follows the policies and procedures and all the steps required, right? They don't take shortcuts. They have good critical thinking and clinical judgment that we're going to talk about, and that they practice mindfulness and presencing, and they really are there with their patients. So, and they follow self-care so that they can care for others. So some of these things will be mentioned again during the webinar. And then using your core competencies and CUSIN competencies. So everybody has core competencies in their healthcare settings. In education and academia, if you're an AACN, American Association of Colleges of Nursing College, the new essentials were published in 2021. So all academic nursing, baccalaureate nursing programs, pre-licensure programs, and advanced practice will be going to a competency-based curriculum. And so with that, there's a hope that that will also promote patient outcomes and improve patient safety by having, a strong cadre of future nurses who will come out with these various competencies, and there's many of them. And you already know what the CUSIN are, so everyone should be practicing and following the CUSIN competencies, and every nursing school has them in their program, so I know all students are taught about these competencies. And then there's the theories, and I'll give you a little bit more information on them. Barrett, Watson, and King are the ones I chose to highlight in my book. And then there's mindfulness, presencing, and self-care. So I'm just going to go back to the theories of Barrett, Watson, and King. So Barrett, Elizabeth Barrett, she had the theory of knowing participation and change. And so the piece of her theory that I've subscribed to and that I've used for myself is her power prescriptions. And I believe, and again, this is not based on evidence, but it's based on my anecdotal evaluation, is that, and it's based on her work clearly, that using power prescriptions with patients and self can be very, very valuable. And there are studies that show that one of the ways to improve patient safety, and this is from the AHRQ, is that you involve the patient and the family in the care, right? Because when the patient and the family are knowledgeable of their care and what their, plan of care should be, what medications they're having, what treatments they're having, what the outcomes should be, then there's greater improvement in patient outcomes and there's a decrease in adverse events. So with Barrett, it's really helping patients understand you can't give them power, but you can give them the tools to take control of their health and their outcomes. And then, of course, Jean Watson is her caring healing science. And so using her theories, and I'm not going to discuss them in great detail here, but using her caring theories can really help you promote positive patient outcomes with your patients, right? And a lot of the things we're going to talk about, like mindful presencing and self-care, relate to the theorist, particularly Jean Watson and her characters. And then Imogene King is again taking charge of your health. And so her theory is that you are going to you work with your patients mutually so that you help them to achieve their goals in their patient safety goals. So those are just three of the various theorists that I chose to pick on. And King is the theory of goal attainment. Okay. And then there's mindfulness, presencing, and self-care. Again, what does that mean? So mindfulness is really having yourself make an intention that you're going to be mindful with your patient. And some people call this relationship-based care. And even presencing. So before you go into the room, you kind of center yourself, you put yourself in a place where you make a commitment to be present with your patient and your family members. And you do that even before you enter the room. You kind of get yourself in a place where you clear your mind and you are going to focus solely on this particular patient at this particular time. And when you go in, you're not thinking about, I have 25 other things to do today. You're just thinking about, here is my patient, XYZ, and I need to be here with them at this moment. I'm assessing them. I'm doing an intervention. I'm giving them their medication, and I'm not being distracted. I'm really focused on them. And then self-care is important for us as practitioners and also to help teach our patients about self-care. So there are lots of studies that in order to be present and mindful and a caring, healing nurse, you have to take care of yourself, right? You have to be in the best place you can be so that you're focused on what you have to do for that day. And, being a nurse or any other healthcare provider is certainly not easy. It's very challenging. Some days are more challenging than others. But if you put yourself in the best place you can be, you're more likely to not make an error. And nobody wants to make an error, clearly. And, doing all the things, providing yourself with the tools to prevent errors um, is the key to really having a culture of safety and hopefully zero errors and zero harm at some point. Okay. This is another big area, critical thinking, reasoning, and clinical judgment. And, critical thinking, none of these are new particularly, but there has been a greater focus on clinical judgment recently. And for everybody in academia or anyone who's a nursing student or getting prepared for NCLEX, the next gen questions and the next gen RN licensure exam is focused on clinical judgment because it has been identified as something so vital in making a difference in patient outcomes. So I'm going to go to the next slide, but critical thinking, of course, is your ability to take a situation and think about it and take all the data you have and make a judgment for your patient, right? So they all go kind of hand in hand, and even clinical reasoning. So what would you do for this particular patient, right? When you're doing a clinical judgment, you're noticing what's going on with your patient, right? And then you're interpreting what's going on with the patient, and then you make a response. But then after that, you have to reflect, right? And, the nursing process is certainly part of this too. These are all very, very related, but it's really having a strong knowledge base, right? A commitment to yourself and to your patients, and then looking at each situation and really thinking about it. There is something called intuition and that we just do things, but you still want to consider each situation and think about how it applies to your specific patient because everyone's individualized. Everyone works or reacts differently or responds differently. So here are some things to help with your critical thinking. So looking at an issue or a situation, the purpose, maybe I'm here to give someone an anticoagulant, right? So I know that's what they're getting. And the question or issue would be, is this indicated for my patient, say, right? Are they supposed to be on an anticoagulant? Because we do know that sometimes medications are ordered incorrectly. They're not truly indicated for this patient. So we have to question why. There could be off-label use. We understand that, but it's always better to investigate a bit. What information do I need, right, about this? So I need to know what the medication is. I need to know what the normal dose would be. Is it indicated for my patient? Is this the time? Is it the right route to give to the patient? Have I looked it up? Do I know what to expect? Do I know what to evaluate before and how to evaluate after I give it? What's the response that I should be looking for? So those are some of the things you need for this particular issue that I'm just giving as an example. What are some of the assumptions, right? Assumption that could be that, the patient needs this medication, it's ordered for them. Maybe it's, preventing a DVT, or maybe they're being treated for a DVT. What are the implications? So what are the implications for this medication? Are there any particular interactions I need to look for? What are the concepts related to this? Could be just the concept of medication administration and what's safe. What's the point of view? What's the interpretation? And what's the self-reflection? So these are just, if you go through these exercises, they will help you. And then some of the critical thinking questions are what is this, right? When is it? When did it happen? So it could be your patient has chest pain, right? So what's going on? Patient's having chest pain. When did they start having chest pain? Who's having chest pain? Or who do I have to notify, right? How? How did it happen? Was the patient doing some kind of exertion? Were they just laying there? Sorry, when is repeated and where, right? So where are we? And so asking yourself questions all the time instead of just reacting to something is much better. And being proactive versus reactive is also much better. So just want to pause for a minute, let yourself think about some things. Try to think about a patient situation and think about, or any situation, because not all of you are probably with patients, currently, but think about a situation and how you reacted to it or responded to it. And if you had given yourself some more time to think about the situation, would you have done anything differently? Or, was everything done accordingly? You were happy with the outcome. You had a good outcome and you followed these different steps and you really thought about the situation. So try to think about those types of situations because they can really help you as you move forward. Um, so again, I mentioned clinical judgment and it truly has come front and center and it makes sense, right? Because if you're in healthcare settings, you have to do clinical judgment every single second of the day almost. And so the new NCLEX next gen questions will definitely be focused on measuring clinical judgment. The National Council of State Boards of Nursing have developed a clinical judgment model. TANA's model has been around for a while, so I just, share different ones. Um, in academia, many academic settings are adopting a model, and I, believe healthcare settings should do the same thing so that all of your students or all of your staff are using the same kind of methods to evaluate and analyze and treat a situation. So the TANA's model I put up because to me it's simple. The NCSBN is similar, but it just has more layers to it. So there's the novice stage or noticing stage where you kind of notice that there's a situation, right? Something's happening, so you notice something, right? Maybe your patient is a little dyspnea. And then you're interpreting, right? What's going on? I see my patient breathing heavy. Are they knowing, if you know what their history is, are their airways being compromised? Do they have COPD? Do they have CHF? Do they have pulmonary edema? So then you interpret. And then after you do, you get your information. And again, nursing process is very similar, right? You're assessing. So during the noticing stage, you're definitely assessing. And then you have to reflect. What am I going to do for this patient? So you're really thinking about all these assessments, all these pieces of the puzzle, if you will, or pieces of the patient's presentation, and you make a decision, right? You intervene somehow, and the intervention could be, providing, changing and positioning your patient or giving them the oxygen that they have ordered or calling their healthcare provider or giving them one of their inhalers. Like it could be whatever they need at that point. And then you reflect on it. Was that the best situation? Was that the best response to this situation? Could I have done something differently? Should I have done something differently? So as you reflect, then you analyze and you think about the situation so that the next time you're in a similar situation, your clinical judgment may be the same because you really have done everything. You had a great patient outcome and everything was fine and, promoted high quality of care. Or maybe something didn't go as well as it should have. And you're going to think about that. Even if there was a medication, right? Error, you'd look at it and say, what caused me to have this error? Why did the patient have the wrong bed? Oh, I pulled something out of the Pyxis and I looked at it. Maybe I had confirmational bias, but I didn't do 3 checks. I didn't keep reading and checking and reading again to make sure that was really the right medication or the right dose, right? So maybe it was the right medication, but it was the wrong dose, but I looked really quickly. Or maybe something was going on with the EMR, and so I bypassed the system. Well, I'm not going to do that again because look what happened, right? It resulted in an adverse event. Okay. Um, and I'm sure you can give yourself a bunch of different things. And what I would like to suggest is to do some journaling and write down your experiences, because that can also be very, very helpful. Sometimes it's painful, particularly if you did have an error, because again, nobody wants to make an error, but sometimes things happen. And, I did talk a little bit about errors that are preventable and non-preventable. And just to give you that example, a preventable error could be any kind of medication error. It could be preventing pressure ulcer, preventing an infection. I mean, most of those things usually, if you're following good practice and policies and procedures, would be prevented. Um, an allergic reaction could be considered non-preventable, right? If you didn't know that the patient had any allergies, and this was the first time they had a medication, um, and they've developed a reaction, right? However, if you knew that the person had an allergy to something and it was still given, that's a serious adverse event, right? So that's how things can kind of be either or. Okay. Um, the next part of this is prioritization and delegation. So there's a few things going on here. If you're the RN on the floor, or any healthcare professional, one thing you have to learn is your ABCs of prioritization. And this can be very hard because most of us are going to work in places that you have more than one patient. If you're in a critical care area, maybe you have one patient, but then you still have to think about your prioritization. But if you have to manage several patients, you have to think about, how do I decide which patient needs me first? And certainly your ABCs of airway, breathing, and circulation can help you, or Maslow's hierarchy of needs, because we do have to think about, okay, there's a patient who, who is cold and they need a blanket. But here's a patient, and it's very extreme, here's a patient who is, having severe stridor, right? So those are the simple ones. It's the ones in between that sometimes you don't know who to go to, right? Or maybe you got late on your morning assessment, or maybe you didn't really do your full assessment, right? You didn't really have presencing. So when you did your assessment in the morning, you didn't pick up on some important clues of what was going on with your patient. So this definitely takes practice. I, really love Patricia Benna's work, novice to expert. And so knowing where you are along that trajectory can help you be more mindful of what your needs are and when you need to reach out for more help and support, because it's a learning tool, right? The only way you're going to learn this prioritization is to really be in the moment and be with your patients, and others can help mentor you, but it's something that you have to learn to develop along the way. And certainly critical thinking and judgment and reasoning will also facilitate that. And then there's something called intuition. And, there's a lot of interesting research about intuition and that it's real. So when you go in to visit your patient or patients and you just get that feeling that something's not right today, that's important for you to stop and think about that, right? Maybe you're, just about to hand someone their cup of medication and you look and you say, I don't remember that, that blue pill in there. Maybe I better go back and check, right? Or you see your patient, they're not really exhibiting anything significant, but you just know something's different about them. And so you're going to really do a further assessment of that patient, right? To find out, what's my intuition telling me? Ethics are, I think, what will help us always be a safer practitioner, because it's, do no harm, right? So we want to be beneficent. We want to avoid non-malfeasance. So we want to think about all the things that we can do to promote patient safety. So if we're ethical, we're moral, we're legal, we look at things through those lenses, we're going to always kind of take that extra step, at least I believe, to make sure that we're following all our policies and procedures. We've completed our staff development. We're lifelong learners. We educate our patients. We include them as part of the plan and the process. And that if we do, have an error, because it happens, and there's estimates that many errors are underreported. And those are even more scary because then the patient's having further harm, right? So if the worst thing happens and an error is made, then reporting it as soon as possible must be done, because that prevents further harm to your patient. And it gives them a chance to, if whatever happened, to rectify that situation, right? So that's an ethical person. They wouldn't cover up their errors, even though, it makes you feel horrible if it happens. But it happens to many of us. And the whole thing is to then work on avoiding any future errors and just thinking about what happened and why. And then scope of practice and delegation. This is important because, particularly if you're the RN on the floor, if you are going to delegate to your team, right, you might be working with a licensed practical nurse, patient care technician, a nurse assistant, then you need to know what their scope of practice is so that you could know what to delegate. Not everything can be delegated. And even if you delegate something, you're still responsible to make sure it got done. So we talked about pressure ulcers earlier. If the patients are supposed to be turned in position and, primarily that responsibility was with your tech or your nursing assistant, then you still need to make sure it's being done, right? An assessment has to be done by the RN. So they can make an observation, but you also need to be assessing the patient, assessing their skin, doing their head to toe assessment, and picking up on anything that's untoward. So whenever you do delegate something, you have to make sure that, number one, it's something that can be delegated, and number two, that it was actually done, right? And done in a timely manner. Leadership. There's a lot to be said about leadership, and patient outcomes. And, we prepare, all of us are prepared to be leaders in some ways. We all have different roles. So some of us are more focused on a leadership model. But leadership and patient outcomes go hand in hand. And part of it is the leadership of the organization, right? So that there is a commitment to patient safety, to a culture of safety, to a zero harm setting, to patient education, to adequate staffing needs, to staff development, to excellent policies and procedures, to evidence-based practice, so that to strong communication skills, right? So that the leadership of the hospital, of the unit, everyone's congruent in what they want to do, right? What they believe is really important, and that they're also going to provide the support needed to accomplish these. And if you're in a magnet hospital, transformational leadership has been one of the preferred styles of leadership. In general, it's a preferred style of leadership. I love the work of Cozies and Posner. I used it in my doctoral dissertation. And what they do is they model the way a good leader, or a transformational leader, or a leader who models the 5 practices of exemplary leaders. They inspire a shared vision, right? So that you're a team, right? This isn't just do it because I say to do it. You do it because we know this is the best thing to do for our patients, in our care, right? Challenge the process. So if we are doing something and we still have, one of the highest fall rates, in our hospital, in our unit, in our region, then we need to challenge that and change things, right? We enable others to act. So a good leader will always have set up their leadership and their area so that it functions whether they're there or not, right? So if your nurse manager is off for the day, the unit should still function, right? Everyone should still be following their policies and procedures. They should still be doing everything they should be, whether that leader's there or not. And encourage the heart, right? So encourage you to care, encourage you to aspire to also be a leader, at a different level, encourage you to always do what's right because that's the best thing for your patient. Because, truly, we all go into nursing and healthcare for various reasons, but at the center is our patients. And we want to do everything in our power to promote positive patient outcomes in them and avoid errors to the best of our ability. Well, everybody was listening. Miscommunication, right? So these are all areas of potential adverse events, but communication has been identified as one of the most significant. So thank you. All right. So we're getting close to ending, putting it all together. Um, Everybody needs to be a patient safety advocate. Uh, and so in your respective areas, you want to always be assessing the situation, knowing what is your safety issues at your hospital. If you really don't have any, then woo, kudos to you, right? Um, I know we can get there. There was a time when the error rates had really decreased. All those interventions had been making significant strides, but then it changed again. And it changed before COVID. So COVID certainly had a negative effect, but it changed before that. And one of the things, if I think back to my days in the hospital, and I was staff development, but worked closely with quality improvement. And a lot of times we would put a lot of attention on whatever area, right? Blood transfusion, falls, pressure ulcers, some of those high risk occurring areas, infections, hospital acquired infections. And when we were monitoring things, we were doing like lots of patient education, lots of staff education, lots of, reminders and checking and assessments and all of that. We had good outcomes, right? But if we left that and went on to the next thing and maybe didn't hyper focus on falls, they would start to rise again. So that shouldn't happen. So again, you need to know what's going on in your area. You need to advocate for creating clear policies and procedures that are up to date and based on evidence and clinical practice guidelines, right? We can't keep doing the same old, same old, same old. Things have to change, whether we're comfortable with change or not. We all need to commit to a culture of safety so that we can all do our best to stay current. There's always new things happening. There's, artificial intelligence that's coming out more and more. We have computers, we have technology to rely on, but, technology, we know double-edged sword can be very helpful, but it's not always helpful, right? So we have to always think about it, especially if we're not using it right. There's a lot to be said and that a lot has been written about alarm fatigue. So yes, we have alarms, but if you get fatigued, you don't even hear the alarm after a while. And to me, in everything, we need to do holistic. You have to take all of these things that I've talked about and others and put them all together and then holistically address the situation and holistically address your patients and holistically address yourself, right? What are your learning needs? What are the things that are going to make you be a better practitioner, be a safer practitioner, right? So what are the things you have to do? You have to kind of do an analysis of yourself also. And if you have a learning need, then how do you address that learning need? And how do you commit to being really a lifelong learner and someone who knows how to read the research and evidence so that you can use it, right? And if you don't, not everyone understands completely how to read a research article. But there's ways to learn about that. And there's people who can help you. And you can be the change agents and advocates in your healthcare settings to make things better. So to summarize, 250 deaths per year are due to medical errors. Patient falls, 750,000 to 1 million. Medication errors, 6th leading cause of death. It's important for us to create a culture of safety everywhere. It's important for all of us to develop critical thinking, reasoning, and clinical judgment skills. And the thing is, you can always improve. So you may be a novice, you may be an expert, but there's always new things coming down, or being highlighted or being developed or being instituted. So we need to stay current. And we need to take a holistic approach to our patient safety. And hopefully by next year or the year after, we'll start to really see changes for the good, right? Lower errors in every way. So now it's time for questions. And I want to thank you for listening and participating and sharing your thoughts.
Thank you so much. That was an amazing presentation. I'm going to open it up to questions. So if you want, you can put it in the Q&A box, and I have a few that we can start with. This says, please comment on the best way to coach and support a nurse who has committed an error, especially a significant one.
Very good. Great question. And first of all, from the days that I became a nurse and until now, I think the focus really has been on a just culture, and that's certainly something the Joint Commission has advocated for. So I think the first thing is to never shame or blame, but to sit down and use it as a learning experience and explore with the person. Because honestly, although there are some areas that are, you know, the fault of one particular person, it's usually something within the system that resulted in the error. And that's why if you look at, anything with Joint Commission, sentinel events, root cause analysis, there's always a break in the chain somewhere. So I think taking it from that individual person and putting it into the system and then looking at their learning needs to help prevent it in the future are what's really, really important. And I think even taking a step back is helping us all to really focus on being the safest practitioners we can, from being a student and then into a professional practitioner, so that the safety is always kind of on your mind, but not to the point of fear. Years ago, I remember having a new nurse, and she was actually petrified to give medications because she was so afraid of making an error. So that, fear isn't good. So I would say just really giving someone support and always looking at it from a systems issue versus an individual issue.
Awesome. Why do you think patient safety changed after COVID?
So from what, the research I've done, it seems that a lot of it had to do with burnout and, being overwhelmed. We are facing significant shortages right now. Of course, we're, nurses. I'm a nurse, but this is not just nursing. This is healthcare in general. So on all levels, right? Whether you're, in a supportive area, in another department, or with a specific patient area, patient facing. So I think a lot of it has to do with that we've lost a lot of staff. There's been a lot of mental health issues post-COVID. So I think that probably plays into it. I think the people are more stressed and anxious. So I think, as a society, we need to keep focusing on supporting all of us, right? Supporting everyone, and being aware that there are, issues, mental health issues. And the worst thing is to cover it up. The best thing is to kind of get, whatever help you need that's going to be helpful for you. Again, it's different for everybody, but I think those are some of the things. And thankfully, we still have many, many people interested in becoming healthcare professionals. So we're very thankful for that. And we knew that the nurses were going to change. I think as far as shortages, but I think also with errors, I think we live in a very stressful society, even before COVID, right? And so when you're always kind of busy, 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 and sometimes you don't even have time to catch your breath, it's easy to make an error, right? So if you're tired, you're fatigued, you're overwhelmed, you don't feel like you're getting the support you need, then it's easy to make an error. And we have a lot of turnover, which doesn't help either. A lot of new nurses need a lot of support. We all need support, but particularly our new nurses and other healthcare professionals.
Great, thank you. We have two more questions. Nursing programs have put patient safety in every course. Since number of errors are escalating, what is your feeling of putting a separate patient safety course in our undergraduate curriculum?
I think that would probably be a good thing to do. My only concern is that for those of you who are academics or even as students, we know that we have content-laden courses. I'm hoping that our competency-based curriculum will help to address some of the issues with patient safety, because our students, will come out and they'll have demonstrated our undergrad and our advanced practice nurses demonstrated core competencies that are required for safety. But I think it may be a really great idea. I think also once people, um, faculty, not faculty, staff, new healthcare professionals get into the hospital setting, that lifelong learning is another important piece. And truly, there should be a residency program. The future of nursing has talked about it for every new nurse. And whether you're new to undergrad or a new advanced practice nurse, there should be a residency model because that transition into practice is key also.
Great. One more question. It says, I'm wondering if you think we should create adverse events as part of our lab and simulation work, purposely including them as a part of our scenarios. If we agree that communication is key for seamless patient-centered care, do you think lab faculty need to incorporate SBAR in all simulations?
Yes, a resounding yes. The beauty, we all know that our students need direct patient care experiences, but the multiple benefits of simulation is that you can allow a student to make an error, right? And so having that experience and focused on all of these things we're talking about in a simulated experience, I think is vitally important. And I think it is, something that's key and it should be probably across the board, right? Not just, where I teach, but everywhere. So simulation has many, many benefits and um, having students make errors in a supportive, controlled environment, I think will be very, very helpful. And hopefully more hospitals. I know some hospitals do have simulation labs and simulation experiences. So again, that bridge to you have your basic generalist training, but it has to become lifelong. So I think that's the other key is the bridge to, simulation still is valuable when you're a licensed nurse or an advanced practice nurse.
Amazing. Thank you so much. Um, I just want to let everyone know that for Nurses Week, you can get Deborah's book for 25% off with code nurses NW23 and or webinar 23 as well. Thank you so much for your presentation and to everyone who joined us today. The recording will be available in 5 to 7 business days on SpirePub.com. And happy Nurses Week again. Thank you so much, Deborah.
Thank you, everybody. Happy Nurses Week, and thanks for joining and stay safe.